everyone. Thank you for joining us for our first Health IT orientation class. This is Kate Berry, CEO of National eHealth Collaborative, or NeHC for short. NeHC is a public-private partnership working to advance nationwide health information exchange. Thank you for joining us to kick off our newly expanded NeHC University. For today's program, we are pleased to be joined by Michael Lake, a seasoned executive with expertise in health information technology, and president of Circle Square, a healthcare technology strategy company headquartered in San Francisco. Michael will provide a presentation covering everything you need to know about health IT. We are very much looking forward to hearing from him, and we will have plenty of time for Q&A today. Next slide, please. As many of you may know, National eHealth Collaborative's NHIN University is a series of webinars intended to provide stakeholders with information about the initiatives that make up the nationwide health information network and how they are working with other industry efforts to create an open and inclusive ecosystem for robust, secure exchange of health information. Many of you may be aware that we recently launched the expanded NeHC University program and rebranded it as NeHC University. We will feature new programs that provide stakeholders with a broader view of the health IT landscape. The new NeHC University is kicking off today, and we are delighted that you are with us for our first new class. Next slide. Before we turn the presentation over to Michael, we would like to provide an overview of the new classes we will be offering. In addition to this orientation class, we will offer Health IT Trends, Industry Leader Briefings, 2 Spotlight Learning Series, Health IT Policy and Standards Committee Quarterly Updates, guest lectures, and continuing the 300 series of NeHC University. Next slide. Health IT Orientation is the class you are taking right now. It is everything you'll need to know to have a solid foundation in health IT. We will offer this class on a quarterly basis, and we will bring you updates on health IT topics and new news from NeHC University. Next slide. The next class we will offer are Industry Leader Briefings. These briefings will feature thought leaders in health IT for an in-depth discussion on hot and timely topics. These briefings will be 1 hour and will provide an opportunity for interactive discussion with the experts. This first quarter, we are pleased to welcome the following speakers. Chuck Parker on May 20th, the Executive Director of Continua Health Alliance. On June 3rd, Paul Uhrig, General Counsel and Executive Vice President from SureScripts. And on June 17th, Holt Anderson, who is the Executive Director of the North Carolina Health Information and Communications Alliance, or NCHICA. Next slide. Health IT Policy and Standards Committee's quarterly updates will provide updates for the attendees and on the work of the standards and policy committees and the work groups supporting them. This will help attendees keep up with the pace of that work and understand what's happening and how that work is being used. These classes will provide deep dives into other topics as well, and in particular around the regulatory process. Our first session for the committee updates is going to be on June 13th, and we are very pleased to welcome Jody Daniel, Director of the Office of Policy and Planning from ONC, to kick off the program, which will be held from 1 to 2:30 p.m. Next slide. Each quarter, NeHC will offer 2 different 3-class series designed to provide attendees with an in-depth examination of specific initiatives or issues in health IT. Each series will kick off with an introduction session to the spotlight topic, followed by more detailed discussions. This quarter, NeHC University will offer 2 spotlight learning series, one on the learning health system and a second on accountable care. The Learning Health System series will be free of charge and will begin with an introduction on May 26th featuring Charles Friedman, Chief Scientific Officer with ONC, and Claudia Grossman from the Institute of Medicine. We will continue the Learning Health System program on June 9th with Ensuring the Public Trust and conclude the series on June 23rd with Building the Technical Infrastructure. We hope to have Joy Pritz, ONC's Chief Privacy Officer, as one of the featured speakers for the Learning Health System series. Our second series, Spotlight on Accountable Care, will require a small fee of $200 for the entire series, beginning with an introduction on June 2nd. The series will continue on June 16th with core competencies and potential pitfalls, and we will wrap up our final class on June 30th with models for implementation. Next slide. On June 8th, we'll have Michael Lake deliver a quarterly briefing on the innovations, new developments, and market trends in health IT. Michael has been a healthcare technology strategist for over 30 years and publishes a health IT trends service which combines market intelligence with strategy consulting to help clients leverage emerging technologies to impact their core business. From discussions of major business and policy developments to updates on health information exchanges and health IT initiatives and how they are transforming healthcare financing and delivery, Health IT Trends will provide attendees with the opportunity to stay on the leading edge of the evolving health IT ecosystem. This class will have a small fee of $100. Next slide. Throughout the year, NeHC University will also deliver special one-time programs on timely and relevant health IT issues. Guest lectures will feature topics ranging from special industry announcements to discussions of recent policy or market developments. Watch your email for announcements of these special programs. Next slide. National eHealth Collaborative's popular NHIN University, an ongoing webinar series focused on the nationwide health information network, will continue to be a premier feature of NEHC's education programs. The NHIN University 300 series will continue as scheduled as part of NEHC University. The next class is coming up on Monday, May 23rd, NHIN 303, entitled So Happy Together, Harmonizing HIE Legal Agreements. This is a can't-miss program if you are involved in health information exchange. On June 20th, it will be NHIN 304, HIE Success Stories from the Patient Perspective. And then finally, the NHIN University 360 series will conclude on July 18th with NHIN 305, the Value Proposition, Exploring the National Roadmap for Health Information Exchange. This program will feature Doug Frisma from ONC, and he will discuss the national strategy for health information exchange. Next slide. As always, these presentations, the slides will be available at the URL on your screen, and the recorded webinar will be up within 2 days, and the transcript will be available within 10 days. Next slide. As we go along, please enter your questions or comments into the Q&A window at the bottom right-hand part of your screen. You can also send us an email with questions at info@nationalehealth.org or tweet a question or comment on our Facebook page. At this point, I would like to turn the floor over to Michael Lake, President of Circle Square, who's going to provide an orientation to health IT. Michael?
Thanks, Kate. Welcome, everyone. Looks like a great audience. So flip to the next slide, if you would. There's a table of contents. So this is the idea for today. There's 6 topics. Maybe we'll spend 5 or 6 minutes on each, so the next half hour to 40 minutes. As Kate said, everything you needed to know about HIT. Well, probably not. So the goals, what's this all about? Why are we doing this? What's the purpose? Why are we engaged? A spotlight on the federal legislation is probably the biggest driver. What's up with the electronic health record? What's the difference between that and the EMR? And what are the other programs that the federal government is supporting to help with HIT implementations? And then I think probably the most important topic to me is to look at this beyond the EMR towards practice transformation. The point of all this is how do we change healthcare? And then I'll make some attempt at summarizing this in the end. And then, part of the goal here is to establish school spirit. And we hope we do that with the content and with the Q&A afterwards. So next slide. So, longer-term global trends. It's important to look at HIT against this backdrop of longer-term trends in both health and technology. This does much to explain both the problem and the solution. So the goal is better care at lower cost. The developed societies, Western societies are getting older, and population lifestyles have led to growing chronic disease. It's stretching healthcare systems in the U.S. and elsewhere. We've not been able to stop rising costs and provider shortages in many categories of care, and consumers are demanding more. One hope is that technology can help, and Moore's Law, that's the capabilities of technology are doubling every 2 years or less. Maybe software is probably doing better than that. Mobile devices, smartphones, tablets, computing in the cloud may be arriving just in time. And again, consumers are demanding more. So just the basic demographics and technology really tell a lot of the story. Next slide, please. So here's the federal approach. This slide attempts to explain this approach in a simple formula, but the legislation, as you all know, is far from simple. In my view, it's a brilliant bit of policymaking from an HIT perspective, and how the pieces work together over time to help improve the system. And I'm going to try and get that across in this slide. So first is the ARA High-Tech Bill. ARA is the American Recovery and Reinvestment Act, the stimulus bill. The HIT sections are referred to as high-tech, which is an acronym I can never remember. One focus is to increase automation of physician practices and hospitals through incentives for using technology for patient care. It includes setting up organizations that can help, such as health information exchanges and regional extension centers, and we'll talk about those in a minute. Add to this the Affordable Care Act, which leverages high-tech and targets a new way of delivering care, which is more automated, includes more provider-to-provider collaboration, more patient outreach. One big goal is to get patients more engaged in their own health. So under this bill, insurers have incentives to use HIT as well for patient quality, safety, other medical uses, because these items are now considered medical expenses. And insurers are incented to want to spend 85% of their money on that and only 15% on administrative issues. This is called the medical loss ratio. It's also a big driver. The bill is also exploring a variety of alternative forms of care, including accountable care and medical homes. The medical home idea is about establishing a single point of contact with the whole healthcare system, usually a primary care practice that can get access to a patient's records from other providers with patient permission and see the whole picture of care. Accountable care is the idea that hospitals and physician practices align to provide care to a patient with incentives based on quality metrics and outcomes instead of volume the way it is today. So we have high-tech automating the providers, an Affordable Care Act increasing physician collaboration and patient engagement. The result, then, is this idea of HIT convergence leading to more integrated care management. So So providers will use e-prescribing and EMRs combined with new solutions for care communications that include elements like information exchange and mobile, combined with powerful clinical analytics engines. They can better manage patient populations through these engines and more toward better outcomes. That's kind of the idea. Here's the shorthand version of today's HIT. It's about automating the provider, it's about engaging the patient, and it's about clinical analytics to help us deal with populations and outcomes. Next, please. Okay, this is high-tech and meaningful use. Let's jump into the bill. The major elements seek to improve the use of HIT. Let's take a deeper look here. It's a complex bill, lots of moving parts, but it's designed so that the pieces are reinforcing. So here's two major ideas here. We've talked about these. One is provider incentives, as we mentioned. We're going to reward providers for adoption and connectivity. And second, infrastructure and support. We're going to develop resources that can help them. The provider incentives are significant. They're big. Each physician can get up to $44,000. McKinsey estimates each hospital can earn around $17,000 and change per bed. These are increases in Medicare payments. There's a similar program for Medicaid providers on a kind of a similar incentive scale. The money's spent over 4 years, and there's a disincentive for not participating. The core idea is meaningful use, kind of in quotes, of a certified EHR. There's a lot of help available. Each state has organized a health information exchange to help get connected. There are also dozens of other organizations forming regional exchanges in local markets to help. We have 17 beacons. These are our best examples, the leadership, if you will. They'll share best practices. And each geography has a regional extension center targeting 1,000 to 5,000 physicians, helping them get automated. So you can see it's a comprehensive undertaking. Let's look next slide. We'll look at the timing next. This is important because you can get a sense of how the pressure is mounting on getting this all done. Here's how the timing of the incentives work. Spread over 4 years. So if you're a physician, you start in 2011, you begin using an EHR by the end of September, you can get the full $44,000. You can see how that plays out. You get 18 the first year, followed by 12, 8, 4, 2, total is 44. Same is true if you start in 2012. You can still get $44,000. But if you wait till 2013, you get $5,000 less. If you wait until 2014, you can only get $24,000. After that, the physician is ineligible to get incentives, and the disincentives kick in. In 2015, Medicare billings are reduced by 1%, in 2016 another 1%, 2017 another 1%, so altogether 3%. That becomes the steady state. So you can see, retiring physicians are keeping these calculations in mind to determine their strategies about whether they want to participate or not. Let's look next at the big picture here. All right, so we can see here meaningful use is being proposed in 3 broad stages. It's a big undertaking. So the first stage is focused on the basics. We're going to capture clinical data and begin to share it. Being driven largely by the provider incentives for meaningful use, as we discussed. The second stage, hopefully beginning in 2013, focuses on advanced care processes and clinical decision support. In this phase, we're beginning to look ahead as to where health reform is going. And in stage 3, the focus becomes transformation to a new practices model. It's focused on outcomes and population management. The stage 2 and stage 3 aren't done yet. We'll learn much more about stage 2 in June and stage 3 well after that. But let's look at what we do know, and we can look at each one a little more closely. So next slide, please. So the first stage, as we said earlier, it addresses the basics. There are 15 core criteria, which are all mandatory to achieve meaningful use in this first stage. 10 menu options. Providers pick any 5. These are optional. These meaningful use criteria, they generally describe a basic provider EMR as told by dozens, if not hundreds, of solution providers. Examples here on the slide: collect patient information, e-prescribing, quality reporting. The level of collaboration here in this stage is pretty low. So getting a visit summary to patients within 3 days is, the basic criteria. Let's look at some of the details. Next slide, please. So the focus on capturing, sharing data. In the core set, this is the mandatory stuff, 15 measures, and most of them, you can see the threshold is about half, 50% of the patients. For some, such as problems, meds, and allergies, a higher threshold is expected, 80%. For e-prescribing, entering a medication order, 40% of possible prescriptions. This excludes, I think, control drugs. Similarly, for physicians entering orders in hospitals, CTOE, computerized physician order entry, the requirement is 30%. In some cases, you just have to have the function, such as drug interaction checking, or perform a single test or run a single rule. In the case of quality reporting, blood pressure, BMI, body mass index, smoking status, these are mandatory, plus 3 other measures out of dozens that are related to various specialties. So that's the core set. Let's look next at the optional measures. Next slide, please. It's called the menu set. So you're picking from a menu. It has 10 measures for either physicians or hospitals. A provider picks 5. These are optional because it was thought these are harder to meet, and they probably are. While lab results are ubiquitous, getting them with sufficient structure for analysis is not. Medication reconciliation and summaries at care transitions, this is difficult. It's a difficult workflow. Patient-specific education is also seen as an advanced feature. Sending reminders for preventive care and follow-up care, that kind of stuff, also seen as more advanced. And getting stuff to patients, access to chart summary data, these are all part of the menu. While these last criteria are relatively routine in some environments, such as Kaiser, Geisinger, like that, where they're kind of integrated systems, they're much more difficult in open networks. So that's where we are in stage 1. Let's look at stage 2 from at least what we know. Next slide, please. So we're getting a sense of where it's going. A public-private team of industry luminaries, I think they used to call themselves the Gretzky Group. They've been looking at where the puck is going. There's been extensive public comment, as expected, and the requirements are kind of still floating around. We do know, however, that the intent is to both broaden and deepen criteria to support more advanced care processes. We know that most of the optional elements from stage 1 become mandatory in stage 2. That's the idea. So the labs, the advanced prescribing, the drug interactions, and stuff like that. We also know that the thresholds for satisfying criteria will be more rigorous. So more decision support rules, more prescriptions must be electronic, more patient outreach, like that. Basically more of everything. And the measurement moves, this is a big deal, from provider attestation, from just saying, yeah, I did it, to reporting actual quantities. So in this stage, I think we need both numerators and denominators. And in stage 2, we're getting more and more structured data that can be shared and analyzed. That's kind of a core here. And in stage 2, we want to intensify the level of collaboration between providers and patients and among providers. So it's this connectivity idea. And in stage 2, while meaningful use is still the major driver, providers will begin a transition to using HIT as a tool for transformation. This is the plan. Let's look at, next slide, we'll look at stage 3. We know less about this. So next slide, please. Oh, here, we have it. So stage 3 goals are to use interoperable EHRs as tools for transformation of clinical practice. It's focused on improving outcomes, on managing populations. It anticipates health reform, particularly new provider reimbursement models. In many ways, it's looking beyond the current EHR, although it requires it as a foundation. Stage 3 looks at engaging providers and using EHRs to manage high-priority populations like diabetics. It anticipates collaborative care among providers and routine electronic patient communication outside of office visits. It seeks to support patient-centered medical homes and emerging accountable care organizations. So in Stage 3, we'll have the structured data necessary to analyze treatments and outcomes and suggest an evidence-based approach to care management. That's the idea. That's kind of the holy grail. So next slide. So let's look next at the what is the electronic health record. We'll jump into that a little bit, spend a few minutes. So next slide, please. So this is the interoperable EHR, if you will, the electronic health record. It's a concept, and it's a concept of the availability of a patient's health information when and where it's needed. As you can see, all industry stakeholders have a version of this patient record. So physicians have it, hospitals have it, the insurers have it in their claims system, some patients have it in a personal health record, pharmacies have automated and they have a version. So and you can see all the stakeholders have these versions in silos. We want to share information between providers and patients and between providers and providers and among all the relevant stakeholders. That's the EHR. It's a future goal. Providers are being offered incentives to use a system in their office that can feed this EHR. Let's look at what these systems do. So the next slide. So at a high level, this is the EMR, the electronic medical record. It's the core operating system, if you will, for a practice. It either contains or works with a registration and billing solution. It collects clinical notes, billing codes, manages lab and pharmacy transactions. It's a workflow tool for the patient care process in the practice. It's a repository of the patient's clinical records. It's designed to help the practice communicate with stakeholders outside the organization, and it's designed to help clinicians make better clinical decisions and manage better chronic populations. These last areas are significantly less mature. So how is this going? Let's look at the next slide. Well, not very well in some ways. The CDC reports over 50% of office-based physicians have something they think of as an EHR or an EMR. But when asked about specific features, such as patient demographics, a problem notes, a med list, stuff like that, half that number, 25%, say they use one. So that would be a basic EMR. And when asked about more comprehensive functions, such as all the features of the basic system, plus medication history, e-prescribing, test orders, the stuff that we just talked about for meaningful use, particularly stage 2, only 10% report use. So full utilization today of a comprehensive solution remains rare. This is what's going on today. It's a very hot market, with most attention being paid to adoption. Incentives, however, you recall, are more about meaningful use. Let's look at who can help. So next, we have RECs, Regional Extension Centers, HIEs, Health Information Exchanges, and Health Information Service Providers is a new idea. Let's look at first at RECs, what they do. So we hope that RECs can help with utilization. That's kind of the idea. Many are helping physicians select appropriate EMRs by recommending a short list of qualified EMR vendors who are stable and can take the physician on this path. In Massachusetts, their regional extension center is typical, although they recommended a larger list than most over there on the right. These are preferred EHR vendors. It's basically a list of the top 10 EMR vendors. So we're generally seeing a common list of recommendations from most of the regional extension centers focused on industry leaders. They're also recommending implementation support companies, and this is going to help. This should help with the utilization. In Massachusetts, 18 such companies were recommended to support practices in their state. So this is one hope we have, is these RECs can help these practices get going, get the systems installed, and get to meaningful use. Also helping, we think, are the state HIEs. Let's look at that. So this is set up by the federal plan They're emerging slowly, as probably isn't a surprise to most of us, and it's market dependent. So this chart, this is a government view of the program. It's characterizing the state HIEs according to their focus in light of these of the local market conditions. So one group is the elevator. They're going directly after stage 1 meaningful use in markets that have little HIT activity. Speed is the essence here. Another group is the capacity builder. They're focusing on regional exchanges, helping practices get to the first stage of meaningful use. There's no statewide entity yet functional in this group. Another group is the orchestrator. These are the state-level networks connecting existing regional exchanges. And the final model is the public utility. These are the statewide exchanges. They're providing services to end users and regional networks. Now, these occur where there's already operational state exchanges and a strong stakeholder buy-in. The hospitals, took an early lead here in setting up these regional exchanges because they have a natural business reason to do so. They do business with community physicians. So a lot of the early work has been hospitals working with local physician communities. So this, in a way, I think about this somewhat as the noun of health information exchange, about the organizations. Let's look next at HISPs. Next slide. This is kind of the verb of health information exchange. So these are the inter-system protocols. These are being developed. This is a Project Direct protocol that they're being developed to support the high-tech goals because the more complex inter-system protocols, they're going to take a while to work out to get to every use case. But right now, in the interim, we all think that the government's supporting this, and it's called Project Direct. There's a set of protocols that can work really well, exchanging patient information securely between two parties that already know each other. So this works, for example, between physicians for a patient referral. It's a great example. The number of these HISPs are forming. I'm just on this slide citing one example. This is SureScripts. It's using its nationally prescribing network, which already connects about a third of the physicians. They're offering to link any physician to any other physician for $15 a month. This is a deal that they put together with AASP, which is the Family Practice Society. So virtually all the leading AMRs are announcing HISPs as well. That'll connect physicians using their software to others that also use their software. Physician social networks are jumping in saying, well, we can do it too. And Microsoft announced that their patients are using that patients who are using a Microsoft-defined, this is Microsoft Health Vault, an email address, can use this protocol to exchange email messages with physicians. So physicians send you an email, it goes right into your Health Vault chart. So those are the folks that are going to try and help. Let's look next at beyond the EMR. Yeah, that's good. So CMS is proposing rules in their Health Affordable Care Act that stresses it really HIT beyond the EMR. So the first rules for accountable care, they've been released. The HIT bar, if you will, is very high. CMS is stretching HIT, goes well beyond today's EMRs. So here are the core ideas. Better care and lower costs, of course. You've got to scale to at least 5,000 physicians, half of whom must meaningfully use EMRs. That's a high bar. Evidence-based medicine. How do we get there? Patient engagement, outcomes reporting. These are complicated ideas. Telehealth, care outside the office using HIT. And aggregate and analyze data to provide alerts at the point of care. So this is a big deal, and this is very comprehensive requirement. Okay, next. And then we have the ONC's 5-year plan. I love this plan. They call it a strategy. It's more of a tactical plan, but it's really solid. It's a good summary, of the federal approach to HIT, this document. We talked about it at the beginning of the presentation. So adopt EMRs, use them meaningfully, exchange patient information. We want to improve care and population health. Make it secure and private. It's got to be, it's got to be about trust and confidence. Patients have to believe in this. And then get patients empowered. You know, it starts with patient engagement. We have to get patients engaged. And then measure everything. This is about generating knowledge, if you will, about what works and what doesn't work. So that's the broad idea, very ambitious. Next. So one problem, I guess it's a big problem, I think, that the EHRs were first developed, and you probably can see this from that slide we talked about way earlier. It's developed more for internal practice issues. They're less effective in cross-practice coordination. So, for example, here's a recent study of physicians who've deployed an EMR for 2 years. We find validation that the care coordination aspects of an EMR have the most challenges. Internal coordination is okay because it benefits from all the workflow tools in the EMR, but the reported weaknesses are that boilerplate notes are hard to read. You know, this is where the physician just uses a blob of text to report notes. It's not tracking who you send information to, not being able to compare internal and external data. So the study reports 6 principal tasks over there on the right that are necessary for care coordination. These are very basic, and it turns out EMRs have trouble with most of them. So we're going to need something else, or these EMRs have to get more function. Okay, next. Here's what's recommended. This is a recent report in Health Affairs. It cites 4 peer-reviewed studies of medical homes highlighting the positive aspects of an EHR. And if you're a vendor in this audience, this is where you got to go. So it looked at North Carolina Medicaid, Geisinger, and 4 small practices, and then Group Health in Seattle, an integrated system. The authors they also identified 7 domains for EHRs that require development to help medical homes realize the full potential. These are the 7. So EHRs perform poorest in team care and care transitions, most of which are at the heart of a medical home clinical process or a transform process. Major work is also required in clinical decision support, particularly in chronic care management, not a surprise. More work on registries and metrics is also important to support medical home. So EHRs are important to the future transformation of clinical practice, and the current models, I suspect, need much improvement. It's important that we look beyond the EHR for support. This is our big opportunity. Okay, next. So in a nutshell, I'm going to try and bring this together, so then we'll talk about some questions. This is Bill Stead's integrated model, and he's the CIO at Vanderbilt. His thinking's been very influential, I think, in the federal process. This is the idea that there are 4 domains, different domains to IT and therefore HIT: automation, connectivity, data mining, and decision support. And in the federal plan, they come into play by traveling around the circle in a counterclockwise direction. So we start with automation. So we're automating the provider. So this is a focus really on the patient record. Next, we connect providers to other providers, and we begin to aggregate a longitudinal EHR for the patient. We talked about that. That's the connectivity piece. Next, we can mine this data to obtain information about, for example, gaps in care and alert providers through disease management dashboards like that. We talked about that. Then, last, once you have the aggregated data, you can get the health knowledge by comparing treatments and outcomes, find out what works best, and recommend that at the point of care. So, as you probably can see, this effectively mirrors the 3 stages of meaningful use of the federal HIT plan. And it may be the only way possible because the steps seem to build on each other and are required for a complete solution. You can't really start with decision support without automating the practices and getting connectivity. So that's the summary. And then last, I'd like to pitch, one more thing to give you I'd like to talk about that this is really an intro, and I want to encourage everyone to consider our June HIT Trends webinar on June 8th. Let's look at an outline here. Maybe one more. Yeah. So today we stress the roots, the causes, the drivers of HIT, and how the federal programs are shaping the landscape. In HIT trends, we're going to look at how the market is responding. So the presentation is it's a breezy tour, if you will, through 100+ stories, slides pulled from the HIT trends market reports. And on the next page, as a class attendee, you'll also get an opportunity to access this material on a regular basis. I'm pitching this, and I'm hoping that many of you sign up. I'm looking forward to seeing a lot of you in June. Thanks for participating today, and I'm looking forward to hearing from you about today's meeting. I'm going to turn this back over to my team for Q&A. Thanks.
Thank you, Michael. This is Kate. That was really a great presentation covering a lot of ground very succinctly, so thank you so much. We do have a number of questions coming in, so I'm going to just give you guys a moment. You can definitely continue to input your questions at the bottom right part of your screen. But Michael, so we do have quite a few. First of all, what's the difference? We have someone asking, so what's the difference between an EHR and an EMR?
Yeah. So, now that's right. It's a hard point to get across. So the EHR, this is my view, the EHR I see it's more of a concept. It's the integration of all these EMRs. The EMR is the thing that each individual physician practice or hospital or pharmacy or health plan, they all have electronic medical records for patients. These are the records for your patients. But the EHR is across providers and across entities. And right now it's only a concept because we don't really have it, but it's a great concept, and it's at the core of our ideas about health IT and health reform. So the EMR is a specific set of solutions for a company. It's basically, I think about it as the core operating system of these businesses. You can't run a physician practice hardly without an EMR today. But the EHR is all the different physicians using their own individual EMRs from different vendors, and not only the physicians and the hospitals. It's bringing all that information together and making it available somehow to each clinician when it's needed in the service of the patient.
Great, thank you. Michael, another one, you presented some statistics on the adoption of EMRs and sort of indicated, that there's a pretty big gap between adoption and, full use or meaningful use. Can you just talk a little bit about, why is there such an underuse of the functionality of the EMRs?
Well, I think it's hard. I got to say, I think it's hard. And so it's just hard to get these systems implemented. Just go live. There was a story I reported on this last month that I think it was MGMA, but I think it was, I'm not sure, one of the medical societies, I think, did a survey, and they're saying that they call these optimized EMR users that once you implement the system, it probably takes a good number of months, maybe a year in some cases, to implement these things comprehensively. But then it takes even longer to I'm going to put this in quotes, to optimize the EMR. And what this study found is that optimizers are the only physicians that are actually satisfied with their EMRs. And they're the only practices that are actually getting major benefits from it. So it takes a long time, and I think part of the issue is the vendor incentives haven't stayed in line. So vendors they're mostly incented toward adoption, although I think that's probably changing now with the meaningful use rules, we hope. And then secondly, in order to really use these systems, they have to be effectively integrated into clinical practice workflow. And here we're talking about a very complex socio-technical systems change that is basically changing, a lot of stuff about the way you work day to day. And it's so the short answer is it's complicated. And then it takes a lot of commitment to get this stuff done.
So, Michael, if you take out your crystal ball and try to predict, given how hard it is to successfully implement EMRs and practices, I mean, if you were going to try to predict, so what do you think the impact of the high-tech incentives might be on actually getting people past those significant change management?
Well, we're going to see adoption because that's definitely happening. So, California just released, I think the California Healthcare Foundation released a report this month or last month that 65% of, and I might not have this right, but well over half, and I think it was about 65% of physician practices in the I think over 3 or over 4, something like that are automating. So it's definitely a mainstream market, and it's the hottest market we've really ever experienced. But the meaningful use rules though are I think stage 1 will be okay, and I think we'll get enough utilization for in most cases for stage 1. But and we're still talking about stage 2. There's a lot of pushback, Kate, as you know, on the stage 2 rule set as being too aggressive, particularly in the area of quality and some other areas. So we don't know where all this is going to play out. I got to say, given all of the enormity of the effort, I mean, it's an audacious plan. It's going pretty well. You got to say, I mean, we're automating these practices, and we've got organizations in place to help. We're well on our way. I'm an unabashed fan of what we're doing, so I'm very optimistic.
Michael. Yeah, that's good. So how about in your overview of the kind of the support programs to help make this happen? We have a question about how do the regional extension centers and the HIEs work together in the communities? Can you elaborate on that a little bit?
I don't think I can. I'm not close to the operations of those companies. I mostly see the effects, if you will. So I don't really know details about how it works in the community. Kate, maybe you could take a shot.
Well, I mean, my observation. I mean, I think I guess I would just say that in many of the states, there is a lot of overlap in the stakeholders that participate in each of those programs. So the regional extension centers and the HIEs, a lot of times, a lot of the same stakeholders are at the table in each. So I think there's some natural synergy there, and I think like anything, there's some variation in how effectively it's happening. But I definitely think both the ONC team as well as the teams in the field, if you will, are trying to find the synergy across those programs.
No, that sounds right. Although my only pushback on that would be to follow the money. So to how these organizations are getting their funding would largely determine their activities.
Right.
To the extent that that's aligned, I think we're good.
And that makes sense.
Yeah.
Now, shifting gears a little bit, so we have a question that has come in around, okay, so are there incentives for providers who are not specific to Medicare or Medicaid beneficiaries?
Well, there will be. There aren't, but there will be. Right now, the money is Medicare and Medicaid. That's my understanding. But I think there will be from commercial insurers who have jumped on board, I think, in a big way, and will be putting their own programs in place, creating clever incentives for physicians, particularly in the areas of setting up accountable care organizations. So I do think there'll be opportunities, even if you're not a big Medicare or Medicaid provider.
Right, and I would just add to that. Certainly some of the private plans have incentive programs to encourage the adoption of technology and incorporate that into their own bonus programs. So I think that would cover commercial patients in addition. I think it's been important that the government payers stepped up also, but certainly private plans have, to some extent, led the way there for a number of years.
I think that's right. I think there's a great alignment, which I think has surprised us both, but it's terrific.
Right. So Michael, we have a question. Could you, can you provide you talked about the HISP, the Health Information Services Provider, if I got the acronym right. I have struggled with that one. Can you provide another example or two of?
Yeah, sure. So, let's see. So, I talked about Health Vault. The three I mentioned were SureScripts, which is leveraging its own network. The EMR vendors, so Allscripts announced a referral network. Almost every EMR we're going to expect now to hear an announcement that they will be using these protocols, this direct project protocol, to send information between providers that know each other and that are using versions of their own solutions. I haven't completely tracked which ones have announced yet, but it wouldn't surprise me that all of them at some point will. And then from the patient side, I really did like that idea of Health Vault also jumping in on the becoming a HISP, in that they could use the direct project protocols for patient-provider communication. And then I mentioned social networks. So Sermo is a social network of physicians. I'm not sure I'm going to get there. One I don't remember the pharma. One of the pharmas, it might be J&J, is doing working on a project with Sermo. Sermo is a social media network of physicians, and they want to use that structure to use the direct protocols to send information between and among their members. And we heard that also from a startup called, I think it's Doximity, which is another social network for physicians. So the interesting part about this, about the direct project and about HISPs in general, is that this lighter weight protocols, that can work right away and between people that generally know each other, can deliver a lot of value here in lots of different circumstances before we have the full NHIN infrastructure built.
Great, Michael. Thank you. So now we have also some questions sort of around, back to the challenges of implementing IT and practices in hospitals and achieving meaningful use. So from your perspective, what are the hardest aspects of meaningful use for, let's say, a practice or a hospital?
Yeah, so it's all the communication stuff. It's provider collaboration, and it's patient engagement, and then it's the analytics required to do the quality reporting. So let's look at them maybe a little bit one at a time. So the idea that you do have to be able to reach out to the patient, and it's just not as mature an area of HIT, and so the people will struggle there folks are struggling with that. And then the provider collaboration also, the idea that you have to be able to, smush these records together is another issue. So being able to send summaries of care to other providers and to patients has been a big deal. Just the idea, some simple things is not so easy. So getting those lab results structured, even though everybody has lab results, 90% of the practices get lab results, but they get them in a way that they're a big blob of text, or it's like a bitmap or a picture of the lab result. Getting it all structured also is also very difficult. So for me, it's the issues that we talked about in this meeting that I talk about as beyond the EMR. Those are the areas. It's registries. It's more in stage one. I think the issues are going to be what we just mentioned: is the patient and the quality metrics. But in the future, it's more about the practice transformation and all those areas that need to be developed that EMRs really don't do well now. There's going to be a whole new class of technology that's focused much more on care management and care communications, my view, being driven by providers.
So the questions are really flowing in now, and I do just want to let our attendees know that if there are questions that we're not able to get to in the remaining time, that we will document the Q&A and post it on our website. So we'll try to get through as many of these as we can, but I just want you to know that if for some reason your question doesn't get answered, we will get it answered after the program. So Michael, on that, and you had a slide on this, but on some of the more, I guess, newer functionalities that are needed to do the practice transformation, like you mentioned, registries and the care transitions and so forth. Are these functions currently available in most of the EMRs in the marketplace, and if not, how are we going to get access to those functionalities?
Well, this is my view. They're not. So I think they're rudimentary. I think many of these functions that we've been talking about are there, and EMR vendors can implement some functionality in these areas, but it hasn't been a focus. Their focus, rightfully so, has been automating in these domains of HIT that we talked about in the summary. The EMRs are all about automating the practice. They're the core operating system. So all of this is newer, and the big guys are doing a good job. They're adding functionality. They're buying stuff. They're going to add. So there's a lot of innovation going on in these areas around registries and team care and reaching out to the patient, care management, mobile. There's tremendous. What a tremendous market! And some of that market, the big EMR vendors are going to be buying those services and intellectual property to incorporate into their own systems. As well, there are a new class of solutions that describe themselves as kind of clinical groupware or collaborative computing or some such thing that will be an add-on to an EMR that might be from some newer vendors. So I think this is the area where we're going to get a lot of innovation, and this is the area that's it's hard too. It's a hard area to automate. But and the biggest issue is I think the patient. So it's that we're coming together with how providers collaborate and how they reach out to patients, and in a new transformed care process. The technology to support that. It's all new. And what a tremendous opportunity, And I think it's going to work too. I mean, everything I see, it looks like we're going all in the right direction, and that this technology is coming on board. I can't tell you the innovations that I see every day are just mind blowing. I mean, the thing that we talked about the very first thing we talked about of how the technology is growing so fast is, it's really incredible. We're getting a lot of help from the startups.
Great. So, can you? We have a question. So here's one. Michael, can you provide an example or two of how Health IT is being leveraged to support better patient engagement?
Yeah. So the idea here is that if you have an analytic engine that can look across all the data that we know about a patient because we've brought this data together somehow, and we have access to it. So it's data, from the lab and from the hospital and from all the physicians, and it's data that patients have entered about themselves. So what we could be able to do, and what we're starting to be able to do now, there are companies that are offering this, is we look at that data and we can both, first of all, we can predict which patients are the most vulnerable and that we need to reach out to. So one of the earliest uses now is for diabetics. So we can reach out to diabetics and make sure that they're getting their hemoglobin A1C tested. We can reach out and make sure that they're doing their glucose testing every day, and we can actually see these glucose scores come rolling in through remote monitoring, and we can. So it's the basic idea is moving away from having patients need to come in to the practice in chronic care situations and do a lot more managing of this over using the internet and particularly mobile technology. We're seeing Kaiser. I'm a Kaiser member. I live in California, and fully 40% of their patient visits are now electronic. And so, and I'm a hypertensive. I won't complain about my health, but it's unbelievable the value of being able to use these kinds of patient-oriented tools to care for a chronic disease. It just makes it easy.
Great. Thanks, Michael. So we have a question about, I guess this is going back to the importance of the exchange of information among providers in order to, coordinate patient care. So the question is, will there be standards to help all of us be able to transmit that data to each other or to some central?
There are. That's what we're all working on. That's exactly right. There are standards. I'm not as close to the details of that, but the core ideas about patient at least status and summary are we have a number of standards organizations that have done really great work. So it's the blanking on the
HL7 for some and NCTDP for medication related.
Yeah, but what's the HL7 one?
Are you thinking of the continuity of care?
Yeah, continuity of care. So So I think those standards are maturing and are going to be very important.
Right. And
I got to say, it's not just here. So what we're starting to see now is that I know our focus here today is the U.S., but we're seeing Europe and actually these are global issues, and increasingly as societies are looking to deal with them, there's a lot of standards work that's going on in Europe now that is getting much more aligned with the work in the U.S. And another group I'll give a shout out to are the folks that are working on the inter-system on the device protocols, so we can let all these medical devices that patients can use to collect data out in the field and communicate back to providers to get that those protocols kind of in line, and that's a global effort.
Right. Good. So, I mean, it seems like,
That's
some standards are in place. Yeah, some standards are in place, and where they're not, there's organizations and work to develop additional.
Yeah, the government has been diligent, I think, and clever about its standards work.
Mm-hmm. Here's one for you, Michael. So and I'm not exactly sure what's behind this. This may be a little bit of a loaded question, but so the question is, don't vendors have an incentive not to cooperate? So I don't know if you want to comment on sort of the vendor incentives and how they're supporting their customers, or I think so. There's a question around that, the vendor engagement.
No, I don't know. I think the only vendor politics I think that's going on, and I would say it's significant, is the large vendors that are extending their lead, I guess. So there's a politics there, in that and this has something to do with the federal program, but it's just the way markets work. And so in early adopter markets, companies win by providing great new products, and because what the market looks for is technology advance and clever new products. They're focused on features and functions and all that. But in a mainstream market, particularly in an overheated one like this is, what the market cares about is just market leadership. So they're picking companies because they are already winning, if you follow what I'm saying. It's not about it stops being about the product, and it becomes more about the company, if you will. So
they know they'll be around.
Yeah, I know they'll be around. And so, like, an interesting statistic is this class, KLAS is an industry analyst. They're finding that well over a third of the deals are takeouts, EMR replacements, for physicians that already have an EMR but are scared that their vendor can't take them to the end. And that's true in hospitals as well. In the community hospitals, they put out a report that said 20% of the hospitals, of community hospitals, these are smaller hospitals, are going to throw their vendors out. And so there's these lists now of kind of who are the safe vendors and who are the risky vendors. So there's a politics, and the new players, resent the dominance of these. But this is business.
Right. So, okay, but back to we have a question about following up on your comments about e-visits or online visits.
Yes.
So someone is saying, so have they come up with a way for physicians to get paid for electronic visits when a patient?
Yeah, they do. So, they do. And we're seeing the early phases of it. There's two kinds of online visits. Let's call them asynchronous and synchronous. So asynchronous is kind of email. That's where you're having a sore throat and you want to find out if you should go to the ER or whatever. You can send an email to your doctor and you get a response. Or what I do is I instead of going into Kaiser to report my blood pressures, I do it online. So that's asynchronous. Synchronous. And there's a bunch of companies that do that. The EMRs do that also. They reach out to patients in some of the EMRs. The synchronous is more other companies that actually get online in real time, either on the phone or through the web or video or so on. And in both cases, we're beginning to see payers, at least the commercial insurers, slowly step up to this. Almost everyone have programs. We're in its infancy, but the integrated systems, Kaiser, Cleveland Clinic, Group Health, Geisinger, like that, they completely incentivize the physician and basically pay the physician, if you will, to get involved in this. And they're trained in how to talk to patients about the benefits of this. And patients like it. It's better for the patient. The patients don't want to come into the office for this stuff. They want to do it online. And we're getting, the more interesting thing to me is that we're getting huge results, clinical results. So it's better in so many areas. It's better to do this online than to actually go in. We're getting better results, better outcomes, clinical outcomes. It's amazing.
Yes, great. So Michael, so here's one. So how does meaningful use fit with sort of this emerging accountable care and patient-centered medical home?
So they're linked. That's why this is so cool. I mean, so all this high-tech stuff is completely integrated in a way with the Affordable Care Act. So the meaningful use in Stage 2 and Stage 3 plays right into the different arrangements that are being experimented with in affordable care for how we're going to reorganize primary care. So it's maybe tight integration isn't the right
like a bridge.
word, and there are probably some small problems that I've heard about. But in general, I think it's brilliant.
It does.
It's very effective.
Right. Good. Well, so I think this is going to have to be our last question, but you could probably spend a few minutes on this one. I think it's a big and interesting question. So the question is, how do politics affect our national health IT strategy? And I think maybe the line this is.
Well, it seems right now that I might not be the best guy to talk about this. I don't pay that much attention to the politics, but my understanding is, and from listening to both Fox News and MSNBC, it does seem like that it's a bipartisan idea. I mean, it was a lot of support in the Bush administration, and Obama, has picked it up. Now, health reform, on the other hand, called by the Republicans as Obamacare, less so, but I would say dramatically less so. But the HIT components of both my sense is are strongly supported, across the policies. I don't get a sense that we're playing much politics here. Although there's some. So we do hear that there's some lobbying in the states to turn back electronic prescribing and some other, create laws that are in the way of some of this that may benefit very specific stakeholders. But that's all to be expected.
Actually, I think we have maybe a time for one or two more, and we do have quite a few questions still in the queue, so I'm just going to go a little bit longer. So there's one, okay, with respect to the mandatory meaningful use criteria, are there requirements that we need to have in place regarding network infrastructure for the physician clinics?
Oh no! I mean, all of these measures have to do with meaningful use. So it's not about what exists. It's in terms of infrastructure. It's about how the infrastructure is used. So you need an infrastructure to be able to reach out to a patient or to another provider. But it's not. We're not measuring the infrastructure. It's the results of it.
Okay. I think the question was, is there infrastructure that needs to be in place to support that other than the EMR? But it sounds
well, there is. Well, there is in terms of you're going to need, most are using, will be using some version of the internet. But there's going to be that kind of infrastructure too that will be required. And there's an infrastructure for all of these solutions that raises another issue. I'll use this opportunity to say that we're implementing generally this client-server technology all over the country. So you saw from the Massachusetts rec slide who they were recommending as the leaders. And so it's Epic and Allsmiths and NextGen and so on, in the hospitals it's Cerner and Epic and McKesson. But these are mostly client-server systems, meaning that the organization manages the infrastructure. Whereas the more modern approaches are, and where we're going to want to be eventually, is cloud-based and more mobile. That's where this is all going. But it seems like we have to go through this phase first of automating the large institutions first and the practices, and that will probably be mostly with client-server solutions. Although there are a few now, particularly in the physician practice, there are a few vendors that I'll give a shout out to. An example would be Practice Fusion is probably one of the faster growing EMRs that's in the cloud. CareMD is another one. GE has bought a company that's a cloud-based or software as a service EMR. They're marketing it as Centricity Advance. United Health Group and Genix has a product called Care Tracker. So we're starting to see Athena Health. We're starting to see a lot of more effort in these areas, and it has great promise because you can implement these systems quickly. You don't need to put the hardware in, and the more important issue is you can change the software much more quickly. There's not as large a burden on version control. So these companies are putting out new software all the time, and then it's cheaper, and it will let us integrate with the patient more easily. So I think that's our future, but we're going to have to go through this phase first.
So on a more technical level, I guess, so we have a question. Is there a minimum an eligible provider must bill in order to meet the meaningful use requirements?
I don't know. There might be. I don't know.
Okay, thank you. And we have someone who says, I work at a community services board. Will our outpatient psychiatrists have to meet the same standards as a hospital physician, or do you know?
Well, slightly different, but generally the same. So around the edges, different in terms of the quality measures and some other things that are specialty specific, but the basic measures are the same.
Good. Okay. Well, I do think we should wrap it up. And Michael, I want to thank you very much for a wonderful presentation, and I'd like to thank the audience. We had some really interesting and thought-provoking questions.
I'll see you all in June.
Well, let's just wrap up. I do want to ask everyone that's still on the line to just take a moment and complete the very brief survey. We really need your feedback to help us continue to refine our program. So just please take a moment and complete those last questions. And Michael, thank you again, and thanks everyone for joining us today. We do hope to see you at many of our upcoming programs. Thank you very much.
Bye, everyone.
Bye.